I got the information late that we can do a makeup today, but thank you for your prompt response. And I'm very sorry for the last time. It was really difficult for us. The whole day there was no power. Power actually came back very late. And they had also not given us a warning. So, but we can do a makeup as we prepare, of course, for the, I think there's a cut next week, if I'm not wrong. So we were done. I believe we were done with the general anesthetics. We looked at up to the last one where it was the intravenous ones and mainly the barbiturates. We looked at propofol. We looked at ketamine and also the barbiturates where we discussed both methotrexate and also we discussed we also discussed the penton sodium. And I did mention, since you have done the SAR of barbiturate for central activity, this is central activity. The SAR is the same, but the SAR here is restricted to only 2 drugs, one of them being methotrexate and the other one being the penton sodium. The others have either intermediate activity or they have very long duration of activity and they cannot be used as general anesthetics. It's only these two, and perhaps these two that have found very good use because they have a very rapid onset, they have a short duration of action, and we have explained that this is because of their structure. So I think we end there with the general anesthetics, and I want us this evening or this afternoon to start on centrally acting muscle relaxants. As the unit reads, it is CNS, I think 1 or 2, CNS 1 or 2, I think it's 1. So we are dealing with drugs that act in the brain. If we can move fast, we can be able to finish this. Again, it's a very short topic. It doesn't have a lot of SAL because, as we said, these drugs that act, some of them that act in the brain, they have very many different structures. They have no relationship because most of them just block certain pathways and you are done. So we'll be looking at the central acting muscle relaxants. Again, a very, very short, I think about 33 slides. So we should be able to finish it, I hope, today. And if we do, then we go to our last, which should be the CNS stimulants and the hallucinogens. So centrally acting muscle relaxants. Why central? Because we have 2 classes of muscle relaxants. We have those which act peripherally and we have those which act centrally. So our interest are just those ones that act centrally, and of course, more often than not, act centrally for relief of pain. So centrally acting muscle relaxants. So let me enlarge this, please, with your permission. So centrally acting muscle relaxants, they reduce skeletal muscle tone and are used in treatment of muscle spasms. This is just pharmacology, muscle spasms of local origin, such as strains, sprains, lumbago, spasticity, and spasms. Also relieve pain and spasms associated with quite a number of these conditions. You can see there, again, a lot of pharmacology there. Centrally acting muscle relaxants that are widely used include baclofen, cyclobenzaprine, carisoprodol, methocarbamol, chlorphenicin, chlorzoxazone, ofenadrine, and diazepam. Ofenadrine, I think we have dealt with these. Ofenadrine, I think, is even also in the class of the histamine antagonist. So diazepam, again, in the class, you have also studied the benzodiazepines. So as you can see, there are some of them which belong to specific classes. The others that are just standalones on their own in their own specific class. So centrally acting skeletal muscle relaxants selectively depress because they are centrally acting for pain. So for you to relieve pain, you must be depressing the CNS. So they selectively depress the CNS that controls muscle tone and suppress motor impulse transmission in interneuronal synapses of the CNS. Again, that's a lot of pharmacology. That's not really my area. They reduce muscle tone by selective action on cerebrospinal axis, depress the spinal and supraspinal reflexes of muscle tone. I believe you are very good in this because of your pharmacology. They depress monosynaptic and polysynaptic reflexes of ascending reticular formation. That is, wakefulness is disturbed, sedation. They bring about sedation or decrease anxiety and painful spasm. So they will bring about sedation. There will be decreased anxiety and, of course, decrease in painful spasm. No effect on the neuromuscular junction, but reduce upper motor neuron spasticity and hyperreflexia. Hyperreflexia is where you have exaggerated reflex. The reflex action is exaggerated, hyperreflexia. So that, again, is a lot of pharmacology. So let us look at their classification. When you look at their classification, you have the glycerol monoethers and its derivatives. And under glycerol monoethers, you can see glycerol mono, they are ethers. We have mefenacine, chlorphenacine, chlorphenacine carbamate, and methocarbamol. All this, you see, when you look at their structures, you'll be able to see that they are all related, and that is why they belong to the same class, the glycerol monoethers. Then you have the substituted alkane diols and its derivative, where we'll be able to look at meprobamate. And meprobamate is usually derivatized so that it's given much more activity, and it can be derivatized into a drug like carisoprodol. And then you have metaxolone, and lobamate is not in clinical use, so there's not much to do with that. Then you have the benzodiazepines. We might not discuss fluticasone. I think we discuss diazepam and another one like alprazolam. And you have done the benzodiazepines, you know the structure of benzodiazepines. So I'll just remind you just a bit of that. You have, of course, studied that they are used as sedative hypnotics. They do relieve anxiety. There are even some of them that are used as anticonvulsants, depending on their structure. So we do have benzodiazepines also being very good muscle relaxants. Then you have the benzazoles, and where you have the chlorzoxazone, and then you have the GABA receptor agonists. So these are GABA receptor agonists. Remember, GABA is an inhibitory neurotransmitter. GABA is an inhibitory neurotransmitter, and being an inhibitory neurotransmitter, when it binds the receptor, when it binds its receptor, it increases or it opens the chloride channels, and the chloride channels is an inhibitory channel, and therefore, in being an inhibitory channel, then that means it will bring about depression, and hence, of course, relief spasms and pain. Then you have the tricyclic unrated compounds, where we have the cyclobenzaprine, and now again, one compound, and then you have the miscellaneous, where we might talk about phenadrine and dantrolene. So you can see there are not many, like when you look at the benzazole, it's only one drug. Look at the GABA receptor, it's again only one compound. So that's why I've said it is not a class, or it's not a group, a subtopic that should take us long. So we start with the glycerol monoether and its derivatives. That is mefenacine and cogenase. So you can say glycerol monoethers, and we're looking at calling it glycerol. So if you look at it, you have this is the mefenacine, so that's a structure. You can see you have OCH2, CHOH, CH2OH. Can you draw the structure of glycerol? Can you draw the structure of glycerol? Just check it up and draw the structure of glycerol. Which I hope you have drawn. And that's what I'm trying to. So if you look at the structure of glycerol, this is indeed the structure of glycerol. Glycerol will have CH2OH, and then a middle CH2OH, and then a middle carbon, which is CH2, again OH, and then the final one, which is CH2OH. So this indeed is the structure of glycerol, and that's why we are calling it glycerol monoether, because you can see it is being derivatized to give us an ether. So in all of them, the glycerol is derivatized with another compound such that we get the ether. The ether is, of course, this group there, and the ether is that group there, and this group here joined through an oxygen. So if you look at all these compounds, you will find that they are derivatives of glycerol, and that's why we are calling them glycerol monoether. So if you look at that, it's mefenacine, and then if you look at chlorphenacine, you see that the difference is very small. If you look at chlorphenesin, this is the terminal hydroxyl group of the glycerol or mefenesin, and then you see you have derivatized it into a carbamate. So you have derivatized it into a carbamate, and of course you can also see, of course, there's a slight difference. In mefenesin, you have this is toluene. A group there is toluene. And in chlorphenesin, and that's why you have that chlor, you find the methyl group that is ortho to the ether is replaced with a para chloro group with increase in activity. So you can't be able to say, therefore, there is some structural resemblance and structural difference between chlorphenesin and mefenesin, in that, of course, chlorphenesin, even as from the name, it is a chloro derivative. And of course, chlorphenesin is also a carbamate when you compare it to mefenesin, which is actually an alcohol. So that again is one of the differences. Then when another of this, the second of the differences. So where is this not going away? Then if you look, we have also methylcarbamol. And if you look at methylcarbamol, again the same, it carries this group here. See that group there? It's the same group we have there. And you will study why is that group more important than the group that we find in mefenesin. So you have also the carbamate there, and at, of course, the ortho position, just like in mefenesin, the methyl group has been replaced with a methoxy group. And I think that's why you have the meth there. So you have an ortho methoxy group next to the carbamate. And of course, in chlorphenesin, we have a chloro group, para group, and mefenesin, of course, we have the alcohol with a methyl group. So those there are these in this particular class of drugs, and that's why we are calling them glycerol monoethers and derivatives. There is some structural similarities, and we should be able to know as why, or understand why are we derivatizing into the carbamate. Of course, when we look at the carbamate, again, we look at the carbamate, it is an amide, and we have already said amides are stabilized by resonance, and therefore they give the drug more stability. That drug is more stable to metabolism, whereas this, the alcohol, will undergo phase 2 metabolism very, very promptly. And of course, and that makes the carbamate have better activity than the mefenesin. So we have not used systemically, as it is an irritant rather than a relaxant. So you don't use it systemically. Used as a topical application, acts centrally at the cerebrospinal axis. It reduces neuronal excitability, leading to decreased action potentials to muscle fibers, which ultimately produce a reduction in spasticity. It has been observed to block both inward sodium and inward calcium currents in neurons. So again, it has depressant activity. It has depressant activity where it reduces the movement of sodium and calcium. And of course, the movement of sodium and calcium, that is what is responsible for impulse conduction. And therefore, when you reduce that movement of those ions, then you will depress the neurons and, of course, therefore, relieve the pain and, of course, also the spasm. But you can see a major disadvantage. You cannot use it systemically, only for topical application. And its synthesis, again, that's not hard. We are starting with 2-methylphenol, and you add the 3-chloropropane 1,2-diol. 3-chloropropane. You look at this 1, 2, 3. So 3-chloropropane 1, position 1, and position 1 and position 2-diol. So 3-chloropropane 1,2-diol. All sometimes, if you are to name that compound, you can at times you can name it differently, because you can say it is a derivative of, you can look at the longest chain, which is that one, and that longest chain is an alcohol. So of course that would be the that's why we still have that. In fact, so you can if you consider that is the longest chain, then you can look at the substituents and you can say that's position 1. We are considering that alcohol position 1, position 2, and position 3. We are only saying you can also use the UPAC system. They give that position 1, position 2, position 3. So at position, of course, it is an alcohol, looking at that long chain. So we are considering this hydroxyl group to be a substituent and that chloro group to be a substituent. So you usually organize them according to order. Of course, the hydroxyl group comes after the chloro group. So we can't say 3 chloro, 2 hydroxyl. If we are using this pack system, 3 chloro, because the chloro C comes before H, 3 chloro, 2 hydroxy, propane 1O, propane 1O. So this is not the UPAC system. So I'm only saying, you remember, I do believe you studied the UPAC system of naming, where you look at the longest chain, which has the largest number of carbon atoms, and then you look at which functional group is predominant, or which takes first priority, rather, which functional group takes first priority, and then you name the compound, you name it as per that functional group, and that's what we are saying. This can be called propanol. And of course, now we look at deposition. It has 2 substituent. It has the hydroxyl group at position 2. It has the chloro group at position 3. We do not arrange them according to the number 2 and 3. We arrange them according to the substituents. And that is why I'm saying, although 3 comes after 2, we will start with 3 chloro and then 2 hydroxyl, because it is the substituents that we arrange in alphabetical order. We arrange the substituents in alphabetical order, not being really bothered about the number that is the number which the substituent carries. So that's why I've said we call it 3 chloro, 2 hydroxyl, because chloro comes after chloro comes before the hydrogen. So you can name it in that manner also. So we are saying, therefore, you take your 2-methyl phenol. I'm only reminding you that you definitely did organic chemistry, and when you do organic chemistry, you do UPAC system, and I believe you did that. So the 2-methyl phenol, you combine the 3 chloropropane 1,2-diol, and you lose a hydrogen chloride, and it will give you the mefenacine. So alkylation of O-cresol, that compound is what we call O-cresol, orthocresol, because the methyl group is at the ortho position. O-cresol with 3 chloropropane 1,2-diol affords mefenacine. Then the chlorphenacine carbamate, that will be the next one perhaps. So metabolism, how is it metabolism? It is readily metabolized to its major metabolic product, the toluene oxylactic acid, which is inactive. Because when you look at this compound, you do have this group here. That's an alcohol. Alcohols are readily, because this is a terminal alcohol, it has no shielding, and therefore that group can be changed very easily to the carboxylic group, COH. And once now this becomes COOH, and then you have CHOH and CH2O, that now is lactic acid. That's the structure of lactic acid, and that's why we are calling it toluene. Toluene is for toluene, standing for toluene oxylactic acid. So again, toluene is the whole of this structure there. When you have toluene, you can call the substituent toluene. So toluene oxy, because of that, this group oxygen there, and then this now is the whole of this structure is a structure of lactic acid. So we call it toluene oxylactic acid, and that will be the main metabolite. And of course, that is already inactive. That is already inactive. And we can note that it's easy to get that metabolite because of the fact that we do have a terminal alcohol, which is readily oxidized by alcohol dehydrogenase, oxidized to the carboxylic group. Mefenacine carbamate or succinate derivative show longer duration of action than mefenacine, although less active than the parent drug. Of course, as I had already said, they will show longer duration because when you derivatize the alcohol into the carbamate is stabilized by resonance. It is more stable to metabolism, and therefore the resultant compound will have a longer duration of activity than the parent compound. But as we have said, because of binding the receptor, it's less active than the parent drug. and that is the mefenacin. We have said mainly only used topically, cannot be used systemically because we have said it's already an irritant. Then we have chlorphenazine carbamate, and of course, chlorphenazine carbamate is not the same as mefenacin carbamate. Mefenacin carbamate is as the structure as the phenyl ring with its methyl other methyl group, and then you carbamylate the hydroxyl group. When you talk about chlorphenazine carbamate, then this is a completely different drug because you can't see now the chloro group is also to the glycerol or the glycerol derivative, and therefore that drug is very different. Again, an easy way of synthesis. All you do require is instead of starting with what we started earlier, the orthocresol, this time we will start with 4-chlorophenol, which is quite easy, and then use the same compound, the 2-chloropropane 1,2-diol, an addition with loss of hydrochloric acid. And if that happens, then you get that combination. Of course, now this is just the glycerol, and then you react it with phosgene. Phosgene is C double bond OCl with loss of hydrochloric acid, and you get that compound there. Because you see, you have your Cl there, and then you react with ammonia with loss of hydrochloric acid or hydrogen chloride, and you get your chlorphenazine carbamate. So alkylation of 4-chlorophenol, the propane 1,2-diol, followed by reaction with phosgene and ammonia with loss of hydrogen chloride, affords chlorphenazine carbamate. The phenazine is weakly active and short-lived because of the fast cell metabolism of the primary hydroxyl group. I'm hoping and really hoping that I've done a lot of correction. Just 1 minute. I hope I didn't load the wrong one. Just give me 1 minute. No, I had come to JCOT, so I had to move fast, come and do this. So let me just confirm. Sorry about that. Because I had a structure here to show the product of metabolism, and unfortunately didn't pick it. But as I have said, the product of metabolism is the same structure here, fortunately up to there. This is the only one which changes now to COH. I had the structure, but unfortunately it didn't pick it. So the tall oil is the lactic acid will be OCH2, CHOH, COH. That is the only difference. And of course, we are saying the mefenacin will be rapidly metabolized compared to the other drugs. So we are saying rapidly metabolized with major metabolic product. So that one, I think that therefore mefenacin carbamate or the succinate derivative show longer duration of action than mefenacin, although less active than the parent drug, and that is normally the dose. Usual dose, oral dose is 0.5 to 1 gram for 1 to 6 times per day as per requirement. But of course, again, we said we don't usually use it orally because of the fact that it is an irritant. So we were looking at chlorphenazine carbamate. We've already looked at its synthesis. And then it is weakly active and short-lived because of its fast metabolism of the primary hydroxy group, and therefore that is readily metabolized by alcohol dehydrogenase from the alcohol to the carboxylic acid, and therefore having very short duration of action. And it's the carbamylation to the carbamate of this group increases activity. And why does this carbamylation increase activity? We are saying the resultant carbamate is stabilized by resonance because it has a nitrogen, it has a C double bond, it has a nitrogen. Nitrogen has a lone pair of electrons. There can be a shift of those electrons, and therefore that will stabilize. The chlorphenazine carbamate, or it will stabilize the carbamate more stable to metabolism. And when a drug is more stable to metabolism, then it will have a longer duration of activity. Of course, added to that, the chlorphenazine also does have a parachloro group, and we do know by now halogens ones increase lipid solubility. Halogens also decrease the rate of metabolism of the aromatic ring through oxidative hydroxylation. So the parachlorination will also increase lipophilicity and seals off the para position from oxidative hydroxylation, and therefore the chlorphenazine carbamate definitely again will have much more activity because of the introduction of the parachloro group. Metabolism is still fairly rapid and involves glucuronidation of the second hydroxyl group. Remember, we still have the secondary hydroxyl group, and therefore that drug still can undergo metabolism through glucuronic conjugation, but you can see the secondary hydroxyl group is a little bit more hidden, and therefore the accessibility of that hydroxyl group is a little bit more difficult, and therefore this compound will have a longer duration of activity, better activity than mefenacin uses. And doses of chlorphenazine, it is used to diminish skeletal, of course, muscle spasm resulting from osteoarthritis and vibral disc syndrome. Again, this can be given orally. We are starting with 800 milligrams 3 times daily, reduced to 400 milligrams 4 times daily. You can see there is still not very good patient compliance because these are very high dose, and of course being taken very frequently. That is not very good with patient compliance. Then we go to the methocarbamol. Again, we already looked at the structure, and the synthesis is similar to phenazine carbamate with 2-methoxyphenol as a starting material. So the only thing we are changing is the starting material, is the group that we are starting with. Otherwise, everything else remains the same. Alkylation of 2-methoxyphenol with 3-chloropropane 1,2-diol, followed by reaction again with phosgene and ammonia with loss of hydrogen chloride affords methocarbamol. So the method of synthesis very similar to the chlorphenazine carbamate, only the starting material is what is different. It is a milder muscle relaxant for minor musculoskeletal spasms or in patients who are intolerant to stronger muscle relaxants. It is also used in Parkinsonism and also in cerebrovascular mishaps. Again, these are a lot of pharmacology. I believe you'll be able to do that in pharmacology. It can, of advantage is that it can be given intravenous, 1 to 3 grams per day, administered at a rate not exceeding 0.3 grams per minute, or by IM. So that, of course, can help for people with very, very severe pain, when, of course, when you want the reaction to be almost immediate. What is the SAR of glycerol derivatives? Because we have looked at 3 of them. We have looked at the first one, which was mefenacine, which had an ortho methyl group. We looked at the second one, the chlorphenacin, which had a para chloro group, and we have looked at carbamol, which has again an ortho methoxy group. Are these groups there by chance, or do they have any influence on the activity? So the ortho substituted benzene derivatives are generally more potent than the corresponding para or meta isomers. So they are more potent. But we said for chlorphenacin, the reason why we have put the chloro group at the para position is to block the site of oxidative hydroxylation. And in blocking that site, remember, the benzene ring is attached to an oxygen. The ether has an oxygen, and oxygen is an electron donor. So it is an activator, and it's an ortho para director. So when you have that oxygen, it means the phenyl ring can be metabolized, can be readily metabolized at the ortho position. The ortho position will not be that readily metabolized because there will be steric hydrons because of this other substituent. But the para position is far enough, and it's also activated. It has also got a concentration of electrons, and that is why when you put a chloro group at the para position, you are blocking the site of metabolism, and therefore giving chlorphenacin carbamate slightly longer duration of activity. So that's why we are blocking that position, although we are saying the ortho position results in compounds that have higher activity. In chlorphenacin, we are blocking that position because we want to give it a slightly longer duration of activity. Substitution of a small alkyl, substitution of a small alkyl or alkoxy group in the benzene ring also increases activity. And that is why when you look at mefenacin, it has a methyl group at position, at the other position, and it has also the other one, the carbamol, has an alkoxy group at again the other position, because we have said all those substituted benzene derivatives are generally more important. So it explained to us, and then we have said if you had an alkyl group or an alkoxy group, so the alkyl group as in mefenacin, the alkoxy group as in the carbamol. So that explains, and it explains why are they also in the other position. We have already said when they're in other position, they are more potent, with the exception, of course, of the chlorphenacin, where we are putting it at the para position in order to completely block the metabolism and have therefore give us compounds that have a slightly longer duration of activity. Carbamylation of the secondary terminal alcohol increases activity, and we have already mentioned, and we have chlorphenacin, carbamate, and methocarbamol, and we are saying carbamylation gives you a carbamate, and the carbamate is stabilized by a resonance, and therefore you have a compound that has much more activity because it's not readily metabolized. Parachlorination increases in hypophilicity and sees off the para position from hydroxylation, and we have chlorphenacin, carbamate. So each and every the 3 drugs, there is a reason for the substitution of or the substituent you find in each of those 3 drugs, be it mefenacin, be it chlorphenacin, or be it methocarbamol. The groups that are substituted on those drugs, we can be able to explain them, and because the substitution or the derivatization has been done in order to either increase the duration of activity, to give it more stability, to give it more metabolic stability, to increase the lipid solubility, to block the site of metabolism, and even to increase potency. So we have seen, and we have the 3 different examples which we can give for that purpose. Substitution on the benzene ring, if you put a hydroxyl group, you put an amino group, you put an acetyl group, those groups will decrease activity. So the only groups that are accepted is either the alkoxy group, even a halogen, or an alkyl group. You cannot put a hydroxyl group, you cannot put an amino group, you cannot put an acetyl group. And that ends the first category, which is the glycerol monoether derivatives. We move on to the second category, which is we have finished this, sorry. We move on to the next category, which is the substituted alkane diols and their derivatives. And we have, of course, carisoprodol, we have metaxolone, and we have meprobamate. And if I think we can start, if we look at this, this is a derivative of meprobamate. So perhaps we first look at meprobamate. So if you look at meprobamate, again, you can see it has the carbamate there, instead of the alcohol. That again gives it metabolic stability. And then, of course, it has these two alkyl groups there, again, to promote it, to increase the lipid solubility and allow that drug to penetrate the membranes, including the brain-blood barrier. If you look at carisoprodol, I hope you can see very, very similar to up to this position there. Hope you can see that. Up to that position there, it is very similar. So it is actually the same as this drug. All that has happened is there is an isopropyl substitution on one of the hydrogens. That is all that has happened for us to change meprobamate to carisoprodol. So carisoprodol is a derivative of meprobamate. Of course, metaxolone has its own unique structure. It has, of course, the similarities we are saying, but it has its own unique structure. Again, not completely very similar with the other two. The general mode of action, these selectively depress again the spinal. You can see this word, we are repeating it severally, selectively. It is important for them to selectively inhibit or depress, because if they do not do it selectively, you can understand there are so many neurotransmitters and so many neurotransmitters they can inhibit, and therefore they must be selective for a certain pathway. So these selectively depress the spinal and supraspinal polysynaptic reflexes involved in the regulation of muscle spasms. So they must be very selective to only inhibit the pathways that are responsible for the muscle tone. They do not significantly affect monosynaptically mediated stretch reflex. So that is a meprobamate there. It's a structure of meprobamate. I know as we study, we will come across it somewhere again, I think. And then we look at the carisoprodol. As I said, we do not have much on these drugs. So that's a meprobamate. Then we look at the carisoprodol, and if you look carbamate ester, that is mono and isopropyl, as I've already said, derivative of meprobamate, which is a main metabolite. So it has two chiros. In other words, meprobamate is a main metabolite of the carisoprodol. It is an N-isopropyl derivative of meprobamate. It has two chiral centers and formulated as a racemic mixture. So perhaps you can put a snap, you can take a snapshot of this. This is just the way it has been synthesized. So that is method of synthesis. Again, the method of synthesis are very direct, not very difficult. So you can take a snapshot of that and have a look at it. Then we have the metaxolone. Again, not a very complex. Again, it is still being synthesized. Like the glycerol diols, again, the starting material is what is different, and of course the reagents, because here you can see we have urea is one of the reagents there. So the reagents are different, and that gives us the metaxolone. It is used with rest, physical therapy, and other measures to relax muscles and relieve pain and discomfort caused by strains, sprains, and other muscle injuries. It's metabolized by cytochrome P450 enzymes. Then we have the benzazoles. As I said, I really searched for these compounds and I didn't get much on them. Then we have the the benzazoles, where we have the chlorzoxazone, and this is a very popular drug which you find in some of the preparations when you go out there. You find it in combination even with paracetamol for the purposes of improving on the muscle relaxant property. Of course, paracetamol does not have any muscle relaxant. So like if you have a sprain or you have a spasm, instead of just getting plain paracetamol, then you sometimes you can get formulations out there in the market, and kindly when you go out there, just check them out. You find that you can get a combination of paracetamol and chlorzoxazone. This is because we are saying the chlorzoxazone will help us to relax the muscles, even as, of course, the paracetamol is an analgesic. It is a member of the class of the 1,3 benzoxazoles, benzoxazoles. That is 1,3 benzoxazole 2O, in which the hydrogen atom at position 5 is substituted by a chlorine. So you can see that this is what we are calling our benzoxazole. That's our benzoxazole. And then, so this is our chlorzoxazole. That is our chlorzoxazole. And you find this hydrogen. That hydrogen, as we have said, it is a member of the class of 1,3 benzoxazole. That is 1,3 benzoxazole 2O, in which the hydrogen atom at position 5 substituted by a chlorine. So the whole of this, without a chlorine, when this is a hydrogen, it's what we are calling benzoxazole, and we just replace it with a chlorine to give us the chlorzoxazone. To give us the chlorzoxazone. And we are calling it 1,3, and you can see that's position 1, 2, 3. So 1, 3, benz for the phenyl ring, or start with the oxygen, and zo for the nitrogen. So 1, 3 benzoxazole. So this is the metabolite. This is just to show us when the compound is metabolized, what is it metabolized to? The chlorzoxazone is metabolized with 6-hydroxy chlorzoxazone. That is a metabolite of the chlorzoxazone. Metabolized by carbon hydroxylation at position 6. The 6-hydroxylation of chlorzoxazone is mediated again by cytochrome P450 enzyme, and specifically cytochrome A1, A2, and 2E1. It is rapidly metabolized in the liver and is excreted in the urine, primarily in a conjugated form as a glucuronide. So once, interestingly, of course, you have the chloro there, so you expect that you do not have a lot of metabolism. But again, let us remember, you see this group there? That group there is an ortho paradirector. When you talk about an ortho paradirector, it means it is increasing, or it is activating the ortho position and the para position to undergo oxidative hydroxylation. Also, this group here is an ortho paradirector. So if you look at this group here, that group, look at this group at this position here, that is ortho position, that is meta position. So this is its para position. At the bottom of this one, this is its ortho position, that is meta position. So the one which is really playing the main group, but also the one which is really activating this position. Also, chlorine is a deactivator. Chlorine deactivates the ring, and I hope you understand that. Chlorine deactivates the ring, but also as it deactivates the ring, it is also an ortho paradirector. So amino group, hydroxyl groups activate the rings, but they are ortho paradirectors. Halogens, because of the fact that the predominant effect from halogens is the negative inductive effect, the one of pulling away electrons rather than the one for pushing in electrons. They become ring deactivators. And that's why we say when you have halogens, the ring has lower tendency to undergo hydroxylation. But in case the ring undergoes hydroxylation, they are also orthodirectors. So when we look at this position, therefore, and I'm not, of course, the one who taught you organic chemistry, but I believe when you have been taught, you are said the position which usually undergoes hydroxyl or metabolism is all addition of the group that is coming in, is that where you have the effect maximized. Let's say like we are talking about the orthodirector, paradirector. If you have two groups directing the effect at the ortho position, that position where you have a double effect, like where here we are saying this nitrogen will direct the incoming group, which is a hydroxyl group, because metabolism is oxidative hydroxylation, to this position, which is a para position. This chloro group also will direct any group, although it's deactivating. Even a group is coming in, it will also be directed to the hydroxyl group, to the ortho position. So therefore, you find that this position there, which is ortho to the chloro group, para to the amino group, is the most likely position to undergo oxidative hydroxylation because of the additive director effect from the chloro effect, or from the chloro group and from the amino group. And that is why, although we do have a halogen there, we do still have oxidative hydroxylation of the carbon at position number 6, because, as I have said, the amino group is a ortho para director, and because the ortho group here, there is a lot of steric hydrons from both groups, it can't come here. But the farther the group is, the better, further from the steric effect. The chloro group is also an ortho director, so this position there is the one which has the highest possibility of undergoing oxidative hydroxylation, and that is why we get the 6-hydroxychloroxazone as the main metabolite. And of course, after you get that product, it can very readily undergo glucuronic conjugation. Once it undergoes glucuronic conjugation, it is the end. It will be removed from the body very easily, because of the fact that the glucuronic acid is highly water soluble. The method of synthesis, again, not very complex. So it is synthesized by heterocyclization reaction of 2-amino 4-chlorophenol, again with phosgene. So again, 2-amino 4-chloro. As I was telling you, this is what we are saying. You see, this is 2. Start with amino, although this one is organizing itself very well, and then you go to the chloro, because the substituents are arranged according to the alphabet. So that is a compound 2-amino, 1, 2-amino, and 4. 1, 2, 3, 4 chloro. Again, when we are like naming the aromatic groups, we have the compounds that take priority. When you have all these compounds, like you have the amino group and you have the hydroxyl group. The hydroxyl group takes first priority compared to the amino group, and that is why we are considering that this compound is a phenol. It is a phenol because the hydroxyl group takes first priority as compared. Again, these are things that you do when you are doing the UPAC, the nomenclature of these compounds, both aromatic and aliphatic compounds, and looking at the priorities of the groups, and which one takes first priority, or the order of priority, because that order of priority is very important in the names that you give the compounds. A centrally acting muscle relaxant, again with sedative properties, it acts by blocking nerve impulses or pain sensations that are sent to the brain, used as a skeletal muscle relaxant for reduction of painful muscle spasms such as acute or chronic back pain. Again, as I have said, there is not a lot of Pharm Chem for these compounds. I really searched and searched, and most of what we have is just very little. They are not very commonly used, but of course, as we have said, they are important. They are important, especially when you have strains, you have muscle spasms. They are important because they can help to relieve the pain and the spasms. So the next category is the heterocyclics, and under the heterocyclics, the main class I found here is the benzodiazepines, and I'm happy that you have studied the benzodiazepine. We have already mentioned the diazepam. There is alprazolam. You can see alprazolam is part of the triazolo benzodiazepine. You have the imidazole and triazole benzodiazepines, which I believe you have studied. And then, of course, you have razepam. And as you can see, razepam is in the class of the hydroxyl benzodiazepine. And these ones have a hydroxyl group already at position number 3. And of course, when they have a hydroxyl group at position number 3, then those compounds, those drugs, the ones which have hydroxyl group at that position are usually more safer than the ones that do not have, because these ones do not require to undergo oxidative hydroxylation, and therefore they do not require the cytochrome P450 enzymes, which are usually used by so many of the other drugs. They already have the hydroxyl group, which can just go straight to phase 2. So you find that the benzodiazepines that have hydroxyl group at position number 3 have a much shorter duration of action and have even lower drug interactions. They will have lower drug interactions because they will not have major drug interactions with other drugs that are metabolized by the cytochrome P450, because they already have that hydroxyl group that can go straight to conjugation without use of the cytochrome P450 enzyme. So that is Rolazepam. That is our prazolam. When you look at a prazolam, I believe you did study. This is where you do have the cyclic ring. There's an addition of a third, of a fourth ring, actually. Fourth ring there. And of course, the triazole benzodiazepines are much, much more potent than the other benzodiazepine, either the imidazole like midazolam, and the triazole benzodiazepines are much, much more potent than the other benzodiazepines. Of course, again, diazepam, of course, it has, because of that methyl group, and it can be metabolized to diazepam, which also has activity. So you find that diazepam also has quite a long duration of activity. So when we look at them, we have the long-acting like diazepam, and diazepam, as I have said, is mainly long-acting because of the fact that it has that methyl group, and when it undergoes oxidative N-dealkylation to give us the diazepam, the diazepam is also active, and that gives that drug quite some duration of activity. And then we have the intermediate acting, where you have the alprazolam and razepam have the intermediate activity. So those are the ones, the main three that I found to be really used as muscle relaxant. As I have said, you have done the SAR of the benzodiazepines. Kindly refer to the same. I will only mention it very briefly, because you've done it when you are looking at when you are doing the CNS, the other unit CNS, which I've also taught, has sedative hypnotics, and under sedative hypnotics, of course, we look at barbiturates, we look at benzodiazepines. So I know you have done the benzodiazepines, and I want to believe you also did look at their structure activity relationship, because there must be there are those structural features that are very necessary for the benzodiazepines. Of course, there are those structural features that are necessary so that you call this drug a benzodiazepine. What must it have? Of course, it must have those 3 things for it to be called a benzodiazepine. And then on top of that, it must have some certain specific substituents, which I believe you mentioned. And of course, you can add other substituents. And when you add those other substituents, there will be change in activity. So if you look at this position number 1 here, 1 NR group is optimal for activity. So usually you have a substituent at that position. And like if you look at diazepam, you have a methyl group. And usually when you have a small alkyl group, not a large alkyl group, a small alkyl group is important. It will increase in lipid solubility and therefore improve on the activity of that compound. Then you go to position number 2 here. You have the hydrogen accepting group, whereby you have like this oxygen is a hydrogen accepting group. It can form what we call hydrogen bonds. Hydrogen accepting group increases the activity. So you can have 2 carbonyl group is important for activity. 1,2 fused triazole or imidazole increases the activity. So you have seen, if you have the triazole, it will join there. And if it joins there, it of course will remove the carbonyl group. So we are saying for the benzodiazepines that have a carbonyl group at that position, that carbonyl group is important for activity because it will increase the hydrogen bonding and therefore increase the affinity for the receptor. But you can replace the groups at position 1 and 2 with either an imidazole ring or a triazole ring, like we have already discussed, with increase in activity. And I believe you have done that. Kindly refer, go back to your SAR of the benzodiazepines. Then you look at this position substitution. We have already mentioned here that you can usually have a hydrogen. This is usually a methylene group. In most of the benzodiazepines, these are methylene group. But in the hydroxyl benzodiazepines, this is a hydroxyl group, 3-hydroxyl group. And I've already said, when you put a 3-hydroxyl group, you make the benzodiazepines more polar. You make them more susceptible to metabolism, and therefore usually they have a shorter duration of activity. So substitution with the 3-hydroxyl group can aid the activity with or without. So we are looking at the activity with or without the 3-hydroxyl group. Polar readily converted to the excreted glucuronide, and therefore they will have a short duration of action. Without the 3-hydroxyl group, non-polar undergo hepatic oxidation and active metabolite, and therefore increase the duration of activity. In other words, we are saying when you do not have the hydroxyl group, the position is a non-polar. So it must undergo hepatic oxidation. This hepatic oxidation is the one I was saying usually characterized by cytochrome P450. And that is why I did mention the 3-hydroxyl benzodiazepines are considered to have lesser drug interactions, especially for drugs, if you are giving them with other drugs that are metabolized also by cytochrome P450. Again, when you give them the hydroxyl group there, that position must first go to the hydroxyl group and then conjugation. So that means when you give it as without a hydroxyl group, it is more non-polar. The more non-polar the drug is, or the more lipid soluble the drug is, the longer it takes to be metabolized, giving us a longer duration of activity. Again, this group there, I believe you are told that 5-phenyl group, when you have the phenyl group, it increases activity. Indeed, all the benzodiazepines will have a phenyl group at position number 5. Now, when you even further substitute either of those positions or both of them with halogens, then further increase of activity because of the increase in electron substitution with electron withdrawing group, mainly halogens, will further increase activity, but you cannot substitute position 4. If you substitute position 4, then you will lose activity. As I have said, I'm doing it very generally because you have done it before. Then we go to position number 7, very, very important. And if you look at all the benzodiazepines, they will have an electron withdrawing group at position number 7. Just like position number 6 and number 2, you do require an electron withdrawing group. You can have a halogen, you can have a nitro group there, and that will give you good activity. So you have electron withdrawing group required, and that will be in all the benzodiazepine. The higher the electronegativity, the higher the activity. So when you look at your halogens, starting from fluorine, going to chlorine, going to bromine, of course, fluorine has the highest electronegativity, and therefore you have a fluoro group there, then of course it will give you very much activity. But at times we do remember fluorine is not very common in our bodies. The chloro group is what is common, and that is why you will find most of the benzodiazepines have a chloro group there. But you could even have others the fluoro group. But we are saying you do require an electron withdrawing group. You could also, of course, you have the nitrazepams where you have the nitro group there, which, and you know, a nitro group is also an electron withdrawing group. Then the last is here, effects of the ring A on activity. And I believe you also mentioned that an aromatic ring there, you do require an aromatic ring, and the phenyl ring has maximum activity. You can put heteroaromatic rings where you have hetero rings. So we are saying a carbocyclic aromatic ring, like the phenyl ring there, gives us maximum activity. You can substitute with hetero aromatic ring, but that decreases activity. And that is why all benzodiazepines will have that ring. Of course, even this ring, 7-membered ring, also is necessary for activity. So as I have said, I was only giving the basics. I need you to go back to your SAR of the benzodiazepines for central activity, because Remember, for them to give a central activity or to be muscle relaxant, they must first be able to penetrate the BBB. Once now they penetrate the BBB, you have the specific ones that are able to bind the receptor and give us muscle relaxant activity. But the SAR should be very, very similar, because these drugs must have enough lipid solubility to penetrate the BBB, to get into the brain, because they are centrally acting, to get into the to bind the receptor. And of course, you do know that the benzodiazepines might bind an allosteric site or an allosteric site within the GABA receptor, whereby they will do the same as what a GABA does. So they are inhibitory. They also act. They also bring about inhibitory activity by binding the GABA receptor allosterically. And I believe that all that you have done, because you've done the benzodiazepine. These drugs produce central mediated skeletal muscle relaxation by acting on the benzodiazepine receptors in the midbrain reticular formation and on the limbic system. Act on the benzodiazepine receptors, that is the GABA allosteric receptors, increase the chloride influx or inhibitory action. So they increase is it influx or efflux? I thought they open up and there's a flow of the chloride ions, produce hyperpolarization, decrease the firing rate of the neurons, inhibit the calcium-dependent release of the neurotransmitters. So all we are therefore saying is that they have the inhibitory action, whereby they will open the chloride channels. I will open the chloride channels and increase, I think we are calling it influx, because they will increase the movement of chloride ions into the neuron. And once they increase the movement of the chloride ions into the neurons, then it is an inhibitory activity, and therefore will bring about the depressive or the depression of the neurotransmission. Metabolism. Most benzodiazepine are oxidatively metabolized by cytochrome P450. Again, this is not new. These things we have done. Cytochrome P450 enzyme phase 1, conjugated with glucuronide phase 2, and excreted almost entirely in the urine. You can have microsomal oxidation and oxidative dealkylation, and aliphatic hydroxylation and conjugation. In other words, like when you look at diazepam, of course, the metabolism was also sometimes specific for the drug. Like if you look at diazepam, it has a methyl group, so it will undergo oxidative and dealkylation. My throat has started now becoming a problem again. So oxidative and dealkylation, and then there can be hydroxylation at position number 3 and conjugation. So again, I believe we have only looked at 3 of them. So the ones I would want you to be able to concentrate on their SAR is diazepam, alprazolam, and razepam. Leave the others. And even when it comes to metabolism, concentrate on the metabolism of those ones. Borrow, I will not repeat anymore, because you have done this. And you have, of course, looked at all those aspects. So those are the benzodiazepines, and those represent the heterocyclic muscle relaxants. Then we move on to the next category, and the next category is the GABA agonists. Again, remember, GABA is an inhibitory neurotransmitter. So if you have a drug that can bind the GABA, whether allosteric GABA receptor, where that is where GABA binds, more often than not, they bind allosterically. And then it's an agonist. It will do what GABA does, and GABA increases, GABA opens the chloride channels, increases the movement of the chloride channels, and hence causing the depressive or the depression, or causing the central depressive activity. So we have the drug we are calling baclofen. So this is the structure of GABA. GABA is gamma aminobutyric acid. So we are starting from that as our first carbon, and then we are saying that alpha, beta, and gamma. So this is gamma aminobutyric acid. So that's why we call it gamma aminobutyric acid. So when we look at the compound that we are calling our baclofen, we will see that it is just GABA that has been substituted. You can see CH2, NH2, CH2 here, NH2. So this carbon there. So that is position number 1, 2, 3. The third carbon, and you can see position 1, position 2, position 3. So the third carbon is the one which has been substituted with a para chlorophenyl group. So the third carbon substituted with a para chlorophenyl group, and you can see the purpose of this. This has increased the lipid solubility quite a lot. Increase the lipid solubility, of course, also decreased as a halogen, which decreases the metabolism of that drug. So that drug has good lipid solubility, because if you look at GABA as it is, there's carboxylic group, amino group, very high polarity, it will not be able to give us good activity. Just 1 minute. And allows that drug, baclofen, to be able to access or to pass through the lipid barrier. Again, that is simple method of synthesis there. Metabolism of baclofen, metabolized through oxidative deamination, followed by glucuronic conjugation. And you can see, because of that group there, you can undergo oxidative deamination, and that they are giving us hydroxyl group there, an alcohol. So it is an amine. The deamination is where you have an amine, monoamine oxidases, and then of course it becomes an alcohol. And then after that, there will be glucuronic conjugation. And the minute you have glucuronic conjugation, remember when you're doing metabolism, sometimes you want to, of course, the amino group in itself can also undergo glucuronic conjugation, but I bet when it undergoes oxidative deamination, and you have those enzymes, plenty of them in the body, the hydroxyl group is also more highly susceptible to glucuronic conjugation. So the amino group undergoing and you know also the GABA. The GABA aminobutyric acid. We do have the monoamine oxidases that you metabolize those metabolize the neurotransmitters, and therefore they are readily available in the brain. And I believe that's why they are also able to metabolize that drug very readily. So oxidative deamination to the hydroxyl group, followed by glucuronic conjugation and removal from the body. Useful in treating spasticity associated with spinal cord tensions, as in multiple sclerosis, and that is a dose. Again, I hope you will do a lot of that. In pharmacology, it is also an antispasmodic agent that induces muscle relaxation. Of course, we are saying it's an agonist, and being an agonist, it means it will bind the GABA B receptors, or it will bind the GABA receptors, and therefore trigger the release or open the chloride channels and trigger the movement or the flow of the chloride ions. It uses the release of the excitatory neurotransmitters in the presynaptic neurons and stimulates inhibitory neuro signals in the postsynaptic neurons. Again, a lot of pharmacology. Oral formulations of baclofen are the most commonly used form of the drug. So in knowing that it's an agonist, it's good enough for us to know just to bind the GABA receptors, and once it does so, it will stimulate the release or the opening of the chloride channels, and chloride channels are inhibitory, and therefore, because they are inhibitory, that means they will bring a depression of the neurotransmission, and once you bring a depression of the neurotransmission, you will block the transmission of pain, and of course also will bring about muscle relaxation. Then the other class, as I say, these are small classes. The TCAs, which we call the tricyclic, normally call them the tricyclic antidepressants. So of course the tricyclics are used for people who are depressed and related compounds. So although they are TCAs, here they are not acting as antidepressants. They are actually acting as depressants. Why we call them the tricyclic antidepressants is because they have a specific shape and once you do, I think we studied the tricyclic antidepressants, I think under this antipsychotics. So I don't know whether you did them, whether you have looked at them. Most probably you have, but we call them the tricyclic antidepressants because of the shape they have. But it's important for us to understand, for this specific compound, it is not behaving as an antidepressant. It is behaving as a depressant. So it has a slight structural difference from the kawaida, like the kawaida TCAs like imipramine, amitriptyline, protriptyline, and so there's a very slight structural difference that changes it from an antidepressant, and indeed now it becomes a depressant, so that now it is a very potent muscle relaxant. So again, that's a very simple method of its synthesis. And when you look at its structure, if you remember, if you have done tricyclic antidepressants, I don't know whether you have studied the antidepressants. If you have studied the antidepressants, of course, there are quite a number of categories, including the reuptake inhibitors and all of those, serotonin reuptake inhibitors, all of those, I believe. I don't know whether you have done them. Most probably you have. So if you go back, if you have done them, please go back and check the structure of imipramine, the structure of amitriptyline, and there's something you will find. In the structure of amitriptyline, there is no double bond here. This is a nitrogen in the structure of amitriptyline. That's a nitrogen, so this is a single bond there. So in amitriptyline, which is a tricyclic, I'm wondering, because that word has been mentioned, so in amitriptyline is like that, and then you have the CH2, 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 and CH3, 2. If you look at your amitriptyline has a double bond at this position, but it doesn't have a double bond there. It's only protriptyline which has a double bond there, and I believe it does not have a double bond, it doesn't have a double bond there. So you find that for this particular drug we are calling cyclobenzaprine, the major difference between this drug and the TCAs is the fact that you have that double bond there and another double bond there, which if you go and check in the TCAs, you either have a bond there or a bond here, but you do not have a double bond at both positions. And because of that just structural change, this drug is majorly used as a muscle relaxant rather than an antidepressant. So cyclobenzaprine, so the structure, so you can actually draw, I would request you to draw the structure of also amitriptyline and the structure of imipramine. There is also protriptyline, just for you to compare, and you'll be able to appreciate that the major difference is the addition of one extra bond. And that one extra bond, the structure is completely the same. You have the 7-membered and the 2 phenyl rings, and if you look at the structure here, it's completely the same. And this is this aliphatic chain here, or side chain. As a side chain you get in very many compounds. Even when you look at the antipsychotics, you get the same, whatever. So it's a very, very common structure for quite a number of the drugs that work in the brain. But when I looked at that structure, I realized the main difference is that double bond and that double bond there. And those 2 double bonds give us that difference in the activity, whereby the cyclobenzaprine is actually a muscle relaxant, or it is, if it's a muscle relaxant, we are saying it's causing depression, whereas the TCAs are causing antidepressants. So you can see they have opposite activity. So cyclobenzaprine is one of the strongest, you can see, muscle relaxants. It has been shown to be beneficial in fibromyalgia. It is not an antispasticity drug. 5-HT, it actually also binds the 5-H2 receptor. It's a 5-H2 receptor antagonist. Laxant action is due to the blockade of the serotonergic descending systems in the spinal cord. So you can see it has that depressant action. It has a very specific action of being a 5-HT2 or a 5 serotonin antagonist, which is a serotonin antagonist, and in doing so, it blocks or it brings depression in the descending system or in the transmission within the spinal cord. So what I have asked you to do, so that you can appreciate that are very slight change in structure can cause a lot of activity difference is kindly draw the structure of imipramine, amitriptyline, and protriptyline and compare, and let us compare and contrast that with the structure of cyclobenzamin, which cyclobenzaprine, which is now acting as a muscle relaxant. It's mainly used as a muscle relaxant rather than as an antidepressant. Miscellaneous. I told you this advantage of these ones are not so lengthy. I hope I'll not take a new marathon. Then the miscellaneous, as we had said, we have the dantrolene and phenadrine. And I did mention, I think, phenadrine, we did mention it when we were looking at the histamine antagonists, where we said it has a slight difference in its structure because it has, in one of the secondrines, it has a methyl group, which causes, we said it, which causes a lot of steric hydrans, and therefore the drug is not very potent, not very potent antihistamine. So you can, I don't know whether I've drawn its structure, but kindly, if I haven't, please draw the structure. I doubt I did. I don't think I drew its structure. I didn't. So draw the structure of phenadrine. I didn't even discuss it much because we have also mentioned it, and I know we have discussed it with you under the histamine H1 antagonists. I believe I've mentioned the phenadrine under the H1 antagonist. So you can you can draw its structure, lift what we said about it, just one or two sentences, and we are saying it's miscellaneous. Somehow can't understand how come it causes a muscle relaxant activity, but it does. We do also have dantrolene, and that is, it's an imidazoline derivative there. It's a imidazoline derivative. You can see it there. And this is our imidazoline. That is our imidazoline. These are our imidazoline ring, because remember, when you looked at histamine, it has the imidazole. It has the imidazole, not the imidazoline, because you can see this one does not have a double bond. Remember when we were looking at histamine has this same ring, but it has a double bond, and that is why it's imidazole, and this is imidazoline because of lack of the double bond. So we are saying it's an imidazoline derivative. Of course, it has also this other complex structure on this side. That's a furan, a phenyl furan. That's a phenyl furyl ring. That's a phenyl furyl system, but we are naming it as per this ring. We are naming it as per this ring on this side and saying it's a midazoline derivative. And that's definitely the way it can be synthesized. Again, I don't think it's very, very complicated. And again, do a snapshot of that and have a look at it. That is the way it's synthesized. And mode of action and metabolism. This does not affect the neuromuscular transmission of membrane action potential. Dantrolene works by blocking the release of calcium from the sarcoplasmic reticulum of the skeletal muscle cells by acting on the lyanodine receptor calcium channel. So it has having a different mode of action, whereby we are saying it's blocking the release of calcium ions. And we know the calcium ions are the ones that are responsible. They're the ones that are responsible for nervous conduction. And of course, we know that this particular organ or this particular structure is the one that is responsible for on the renin receptor calcium. It's the one which has the calcium receptors. The renin is the one which has the calcium receptors. So it is blocking the release of the calcium. And once it blocks the release of the calcium, it is basically blocking the nervous transmission. And once it blocks the nervous transmission, that implies, again, a depressive or a depressant activity. There is inhibit excite. So once it blocks the calcium channels, then you will not have any nervous transmission, and therefore it will inhibit the excitatory excitatory system, and of course, whereby you have you inhibit the excitatory system, and of course, the excitatory system usually has relaxation and contraction, and therefore there will not be any contraction, and immediately you will have just the relaxation. Dantrolene is a drug of choice for the treatment of malignant hypothermia. When we were mentioning, in fact, I remember I had said there was something I was going to bring back about halothane, and I don't know whether you guys were born or were within the know-how. When there's this guy who was a very famous comedian. I don't know whether he was a comedian or what we were calling him. Whispers. I don't know whether who used to talk about his daughter as his pajero or something like that. Have you heard of that? Have you ever heard of that guy? He used to write very, very good articles in the Daily Nation, in the newspapers. He used to write beautiful, wonderful articles, very interesting articles. He used to be called Whispers. Did you come across? Have you ever heard of that name? Are you adults then? Or are you in the know-how then? Do you ever hear a guy called Whispers? A guy who used to talk about his daughter as his pajero? Did you ever hear of that guy? Yes or no? No, you've never heard of him. Wow, kwa nini mlizaliwa tu juzi? Hey, there's a guy who used to be called Whispers. And he really used to write very nice articles in the daily papers. And he really, of course, the pajero, used to post of his daughter as the pajero. And of course, calling her pajero, of course, was to, talk about the fact that he expects something at one time. And it was rumored that he died a very funny death, and called for death. I don't know whether one can ever say there is a death which is an emergency or something. But he said that he had a growth, not really a growth. There are these people whereby at the back of their head, there is like a lump. There is a big lamp there, like it's like they have a huge head. But if you look at the back, you will see there is like a tire, and that tire is like a tire of fat. So he was said to have that tire just below between his head and the shoulders. There was a tire there, and that tire I think was a fat. I don't even know whether it used to disturb him or he just wanted to have it done. So he went for a surgery to have it removed, because I don't know whether it was cosmetic or it had any the tire itself had any pathological issues. And it is said that when he went to theatre, he reacted to halothane. And when you react to halothane, it messes your temperature control. And he died. He actually died. It's perhaps about 5 or 6 years ago, I'm not really sure. And this drug we are calling dantrolene is said to control or to be the antidote for that side effect of halothane. Unfortunately, some of these side effects you cannot be able to tell. And when you take somebody to theater, this one will have this. It's like just the penicillin reaction, or some of those we call them idiosyncratic. Just like those ones we call idiosyncratic reactions, whereby they are unexpected. So you do not know who will react and who will not react. So I don't know whether the particular hospital had the dantrolene as one of their emergency drugs or not. But yes, he was called Wahome Mutahi. Thank God the name has come to my head. He was called Wahome Mutahi. And you can Google. He just died just like that. And it was really a shock to almost the whole country. He was a very famous guy that, those guys who have such wonderful articles. So he really, in fact, we used to buy the Sunday Nation, because he used to have his article on Sundays, just to read Wahome Mutahi's article, because it would really be exciting, with a lot of humor and so on. So I think we it was thought that, or it was rumored that Wahome Mutahi died of halogen toxicity, because, as I have said, most probably it's not probably, it is actually an idiosyncratic drug reaction, something you do not expect. And when if you react to halogen, you get what we are calling the hypothermia crisis. Of course, as you know, hypothermia means very low temperatures. So you get the hypothermia crisis, and not unless you have the antidote within reach, then the person could very easily die. So this drug is very, very important. As you have said, is a drug of choice for the treatment of malignant hypothermia crisis. And malignant hypothermia crisis is one, as I have said, of the idiosyncratic reactions that can be caused by halogen. It crosses the placenta and can be detected in the fetus after maternal. Just go and find out. Perhaps you had heard of him. It's only that I'd forgotten his name. But just also go and Google. He was a very famous man. Because of his humor, he had a lot of it. But he went very early. So dantrolene, so it crosses the placenta and can be detected in the fetus after maternal administration. It's slowly metabolized to give the 5-hydroxy and acetamide metabolites. I believe I have its metabolism, the scheme of metabolism. Formation of hydroxyamine during the metabolic process may be associated with liver injury. Whenever you see hydroxyamine, sometimes it's like this. Hydroxy. That group, hydroxyamine. Unfortunately, this group, the hydroxyamine, is highly nucleophilic. Very, very nucleophilic. And whenever you have drugs that are highly nucleophilic, they can bind tissues. They can bind tissues. Very highly nucleophilic sites can be highly dangerous, and because they can bind liver tissues, and once they bind liver tissues, they can cause hepatotoxicity, and that is again one area where it can cause its hepatotoxicity on metabolism. So formation of hydroxyamine during the metabolic process may be associated to liver injury. Dantrolene is available for the intravenous use in vials containing 20 milligrams. Lyophilized dantrolene sodium added to 3 grams mannitol to improve water solubility. You already know what lyophilized is. Definitely this one, we do it in pharmaceutics. So I believe you have done that formulation, some certain kind of formulation, and you can add it to 3 grams mannitol to improve water solubility. It is used for the control of spasticity resulting from spinal cord injury, stroke, and multiple sclerosis. That again is a dosage which is mainly the specialty of the pharmacologists. So we look at the dantrolene, and this is our dantrolene structure. Here we have our dantrolene structure. Sorry, not there, sorry. We are starting with our dantrolene here, sorry. So that is our dantrolene structure. And on absorption, all that is happening is that you give it as dantrolene sodium. So when it's absorbed, the sodium can be replaced with the hydrogen, so you get the dantrolene-free base. And all we are saying is that this drug can be metabolized through several ways. It can be metabolized through several ways. One of the ways is that you can see you have a nitro group there, and that nitro group can undergo nitro reduction to give us an amine there, and therefore that is how we get the amino dantrolene. And then the amino dantrolene can undergo acetylation, so that is just acetylation of the amino group. Hakuna kitu kingine hapo, just acetylation of the amino group to get acetyl amino dantrolene. So that's one way of metabolism, nitro reduction, and then acetylation. Then you can also have hydroxylation, and the hydroxylation will occur in this ring here, and you get 5-hydroxydantrolene, which is that one there. And of course, we did mention more further note, when you get the hydroxy derivative, it can't readily undergo metabolism. And then, of course, this nitro group can undergo also further reduction, can also undergo reduction to the hydroxydantrolene, where you have NHOH, that is hydroxyamine dantrolene, which we have said can be responsible for hepatotoxicity. So that is our dantrolene. And as I have said, very important drug because it is the only one which is used as an antidote for patients. Because again, some of those, as I have said, they're in the idiosyncratic reactions, and you do not know who can have the reaction or not. So any hospital that uses halothane as a general anesthetic should make sure that they do have the dantrolene in their stock. But you see, some of these reactions can take many years. You might the people who are working in that house might not have ever come across such a reaction. So of course somebody somewhere sleeps on their job and they do not realize that you require that antidote in the hospital. So if somebody gets that malignant hypothermia, by the time you would order for that drug, it can be, unfortunately, the person is dead. And these are some of the small issues that us as pharmacists, because we all know all these complications, when we go to such hospitals, we should be able to try and make sure that some of those small issues, or even if it is not within the hospital, the drug is not there because of fear of expiry, it is important that you know where can you get it very quickly. Where can you get that drug very quickly? Because we are saying idiosyncratic reaction sometimes is 1 in 100,000, like the one for chlorphenicol for plastic anemia is 1 in 100,000. But the person who gets it gets a plastic anemia and is condemned to death. So even though it is 1 in 100,000, that person who gets it's a very important patient. And once they get, that's why again we have to be very careful about poor use or what were we calling it, whereby irrational use. That's the word I was looking for. That's why we have to be very careful about irrational use of drugs, because like when you study chlorphenicol, you find, I think you have done chlorphenicol, even a drop, it doesn't matter. And I think we did it with you, we mentioned that chlorphenicol can cause a plastic anemia in any formulation. It doesn't matter whether you used it as an eye drop, whether you used it as an ointment, whether you used it as a capsule, whether you use it as a serum. If you are susceptible to it, you can get the plastic anemia. And you see, although it's 1 in 100,000, that one person means a lot to some people, or that one person is very, very important. And that's why we are talking about when you use the chlorphenicol, that's what we say to them. You have to be very careful. It is a reserved drug. It should only be used when it has to be used. And the same case applies to a drug like halothane, because we are saying this idiosyncratic reaction is fatal if the antidote is not available. So we are therefore saying if we have hospitals where we are using halothane, then we require to know the source of this antidote, whether it is in the hospital or where it can be gotten very quickly, so that you will be able to save the life of that patient. And I think, as I said, wow, are the 3 slides gone? Finished. And let's see if I hope sijampeleka marathon. But as I have said, the muscle relaxant, I really have searched for notes, and we do not have much on them. Again, these are not very commonly used drugs, but again, useful drugs for patients who have those conditions, as we have talked about, spasticity, muscle spasms, and so on. For such sprains, for such people, such drugs, of course, are also very important. So I think with that, we are done with the muscle relaxants. So let's see if there's a question.